Hi, I'm attorney Casey Walker. I'm the founder of VA Disability Group. I used to be a VA disability adjudicator and rater. Today we're going to talk about preparing for knee compensation and pension examinations. Before we get into the discussion of what the examination itself will entail, let's talk about what you need to do before you go to the exam. This is probably the most critical part of preparing for an exam, is what you do before the exam. Don't go into the examination without a single piece of evidence, a written statement that you send to the VA, or some type of diary or symptom log. Do all the above. Give the examiner a reason to think you're credible. Don't just walk in there without treatment. So what does that mean? Well, a written statement, 1 to 2 pages on the knees. I struggle to walk upstairs now. I struggle to get in and out of cars. I can't walk on an uneven surface. I can't walk through the woods anymore. I can't walk my dog off a leash or on the leash anymore because my knee is unstable and gives out. That would be an example of a written statement. Keep a diary or a symptom log. You can go to the description and you can use one of the ones found on our website. But we provide symptom logs free to the public. They are helpful. What do the symptom logs detail? The exact thing the written statement does, but on a day-to-day contemporaneous basis. If you're having discomfort in your knee, if your knee's swollen, if your knee's in pain, if you have locking, if you have some type of patellofemoral discomfort, document it. Don't just hope that the examiner believes you. And then lastly, and most importantly, seek treatment. If you have knee issues, you should be going to a treating professional. And you should be getting a knee brace. And you might be needing injections. And you might need x-rays, or you might need an MRI or a CT scan to show that you have a meniscal tear, or to show that you have some type of crepitus, or that you have some type of ACL or ligament tear. You can't just show up and hope that they think you're right. You gotta document it. So that's step one, and that's the most important part. Document it before you go in. When you go into the exam, you're gonna print it. You're gonna print everything you have and you're gonna hand carry it in, even if you already sent it to the VA, and you're gonna hand it off to the examiner. They might not try to take it, but they're supposed to and required to take it. So just keep trying to give it to them. I just want you to have the evidence. Now, as we get into the examination preparation and what to expect, be advised that we're not gonna discuss every single medical condition under the sun. We're gonna discuss the common knee conditions. If I were to discuss every condition, this discussion would last for hours. So the scope of what we're discussing here today is to really reach the masses to the extent reasonably possible. What are the common conditions that we see with the knee? Well, arthritis is the most common one. Patellofemoral pain syndrome, chondromalacia, sprains with a P, strains with a T. Those are the common ones, but there's a host of other ones. You have ligament damage, ACL or PCL tear, and you might have some type of meniscus damage. The first thing we need to ask ourselves is, well, how do we even get these service connected? Well, there's a direct theory of service connection, there's a secondary theory of service connection, and there's something known as a 3.309 chronic, sometimes referred to as a presumptive, but it's not really a presumptive, but a chronic theory of service connection. So what is a direct theory of service connection? Well, you had an injury on active duty. Maybe you're playing football on some type of base activity, and you get your knee was hurt, and it was documented, and you still have problems with that knee. It was diagnosed as a patellofemoral pain syndrome, and the examiner thinks that the same symptoms you're having today started on active duty. That would be an example of a direct theory of service connection. Again, you need some type of event documenting that injury on active duty. Another theory of service connection would be secondary. Let's say you had a right ankle condition that definitely happened on active duty and is service connected, and maybe you walk with a limp, and you walk with a limp all day, every day, and maybe your gait is altered. Well, maybe you're putting undue stress on the opposite knee of that ankle, and you have a strain or a sprain because of that undue stress. That would be a secondary theory of service connection. Another theory of service connection would be 38 CFR 3.309, which covers chronic conditions. If you look at that list, arthritis is listed as a chronic condition. So what is a chronic condition? Where a veteran develops a chronic condition listed under 3.309 on active duty, they must be service connected. If you develop one of these conditions to a compensable degree within 1 year of separating from active duty, there too, they must award service connection. So arthritis is on that list. You're not gonna get that chronic condition awarded if you didn't get it documented. In this example of arthritis, you would need an x-ray, an MRI, or a CT. You need some type of objective imaging showing narrowing of your joint spaces. Today we're gonna be looking at 38 CFR 4.71a, which is the rating criteria for the knees. We're also gonna be looking at the ranges of motion pictures that are regulatory, so that you have an idea as to what ranges of motion they'll do on the knee. So let's start with the regulation and the rating schedule. We're going to go to Diagnostic Code 5260. You'll notice under Diagnostic Code 5260 that limitation of flexion to 60 degrees would be a non-compensable evaluation. Flexion limited to 45 degrees would be a 10% evaluation, and so forth. Similarly, on limitation of extension, which is a different movement of the knee, Extension limited to 5 degrees would be awarded a 0% non-compensable evaluation. However, if you have extension limited to 10 degrees, you would receive a 10% evaluation. Let's also take a look at Diagnostic Code 5257, which is for instability. You'll notice it says recurrent subluxation or instability. You see this quite often with meniscal tears and ligament injuries, ACL, PCL, and meniscus injuries. And that's a whole different set of compensations that you can receive in addition to the limitation of motion. So be advised, you can get multiple evaluations for the knee. Let's also take a look at Diagnostic Code 5259. You'll notice in the rating criteria on the rating schedule that they discuss semilunar cartilage. But when we look at the examination report here in a second, they actually use the term meniscus. Be advised, semilunar cartilage and meniscus are the same thing for knee and disability rating purposes. So before we get into the examination report, here's the things you need to really keep in mind. Limitation of motion, pain, and instability. Again, limitation of motion, pain, and instability. If you have any type of functional impact, maybe pain specifically limits your range of motion, that as well. But limitation of motion, pain, and instability is what you need to know for the knee. Now, specifically on the topic of pain, 38 CFR 4.59 does actually reference painful motion. And there it states that painful motion will receive a minimum compensable award for that specific joint. So if you go into the examination and maybe your limitation of motion isn't that significant, if you have pain, that alone should make you eligible for a 10% evaluation for that specific joint and range of motion. As we look at the DBQ, let's start with the relevant pages here. We're going to look at section 3. And section 3 gets into the range of motion. What the examiner is going to do is they're going to pull, well, they should pull what's called a goniometer out. And this is a tool that measures ranges of motion. If they don't have a goniometer, let your representative know or send a communication to the VA that they didn't use a goniometer. Now, I'd warn you not to send that in until you get a bad decision, because if you get a really good decision, you don't want to discredit the examiner. But they should be using a goniometer, which is nothing more than like a compass type of tool that they can maneuver and manipulate to determine what your limitation of motion is of that respective joint. Here we're talking about the knees. And once they've determined what your limitation of motion is, they should annotate the flexion and extension of the knee. What does flexion and extension of the knee look like? Well, the VA does provide a picture of this, and you'll notice the knee, when in flexion, is where it's bent all the way back, and when in extension, it is extended up. Now let's take a look at section 6 of the knee DBQ report. You'll notice it references joint stability. If your only diagnosis is a knee strain or sprain, it's unlikely an examiner is going to check a box that you have instability. Usually the instability will accompany some type of meniscus or ligament damage. In the event that you have instability, this is where the doctor or the examiner will annotate that. They might do some maneuvers. We have 3 different videos for you to watch so you have an understanding as to what modality, test, or maneuver they'll do on your body to determine whether they believe you have some type of instability. Not all examiners will do these tests, but take a look at these videos so you're prepared in the event that they actually do one of these modality tests. The Varus test, the valgus test, and the McMurray test are the most common ones. Assuming the examiner has a favorable finding when doing these modality tests, they will annotate it accordingly on the C&P report. That would be beneficial to you because it means that you have documented and demonstrated instability testing. Now let's take a look at section 8, which is the meniscal conditions. And you'll notice on section 8 that they're looking at episodes of joint pain and locking. Those are the most common ones, and joint effusion. Locking, joint effusion, and joint pain. Now, if you were to go to the diagnostic code for that respective condition, those words are verbatim pulled out of the diagnostic code. To the extent you have locking, swelling, joint effusion, you need to communicate it to the examiner. So I hit the high points of the C&P examination report. Now let's talk about unique considerations for the knee. You can receive multiple evaluations for the knee. Now this is uncommon. A lot of joints you only get 1 evaluation, but on the knee you can get up to 3. So specifically if you had arthritis, you might have limitation of motion of flexion, limitation of motion of extension, and you might have instability. If that were the case, and you might have pain on the limitation of flexion, you would be eligible for 3 separate compensable evaluations. 1 for the instability, 1 for the limitation of flexion, and 1 for the limitation of extension with pain. Arthritis can throw another curveball in there, but you can get multiple evaluations for the knee. So it's not a day to be a tough guy. Make sure if you're having limitations or pain or discomfort that you make sure the examiner knows that. Don't push through pain. Don't be a tough guy. Another thing to be aware of when you're in the examination, it is not uncommon for examiners to pull tricks. You might go in there saying, well, my knee, I can't get in and out of seats, I can't get in and out of cars, I can't stand up, I can't ambulate well on uneven ground. And then the examiner says, well, let's move you over to this chair. And they have you stand up and move to another chair, and then they have you sit down. And then they say, well, you know, let's get you back over to this chair. And they watch you stand up again and get back down again. A little bit of trickery, but they're trying to see if you're credible. Because if you walk in there telling them that your knee needs to be amputated because you can't stand up and you can't sit down, and then you're hopping up and getting down from chairs without any issue, your credibility might be shot. So don't embellish, be honest, and be advised that they do these tricks sometimes. I have clients routinely contacting me, telling me they had them bending over to pick something up, getting out of their chair. So you're on notice. So in closing, let's hit the high points. Again, limitation of motion, pain, and instability. Those are the three things you need to be aware of when going to the exam. Have it in order before you go to the exam. Have the documentation in hand to hand to the examiner. Diaries, symptom logs, and treatment. If you have a knee brace, wear it to the exam. They'll probably have you take it off. But don't go in there telling them you require a knee brace and a cane if you don't have them with you on the day of the exam. Be credible. Keep it simple, stupid. Don't embellish. And relax at the exam. The examiner will sense whether you're being credible or not and being honest with them. Well, that's it for the knee C&P discussion. I hope you found it helpful. If you did, subscribe to our channel and check out the description box below for the links we discuss here. Have a good day.